Good evening, everyone. Thank you for joining us. Delighted to have you with us tonight. We hope we have a very informative panel. We know this COVID pandemic has disrupted everyone's lives, and we don't really have, or we haven't had a good treatment, and there's been a lot of anecdotes and charlatans and everything else as far as treating COVID-19, but there is actually something that does show some promise for actually helping, especially if you get the monoclonal antibodies early. And that's a lot of what we're going to talk about tonight. We have a very distinguished panel tonight to lead the discussion. Dr. Saag is going to moderate that, but on behalf of the Medical Association, certainly appreciate you all taking your time tonight. This is done in conjunction with the Hospital Association, and Dr. Williamson, would you like to straighten up anything I messed up?
Thanks, John. On behalf of the Hospital Association, let me thank you, as John did, for taking your time this evening. During the dark days of late December and early January, hospitals were faced with, frankly, overwhelmed beds and overwhelmed ERs. A lot of what you'll hear tonight, the therapies that you're going to hear about tonight, help get us through those dark days. And while we certainly hope that we're on the downside, we know with the emerging variants that we can't be certain that we won't be faced with similar problems later in the year. So again, thank you for taking your time, and we certainly hope that this is a very useful and helpful presentation to help you manage these increasingly complex and difficult patients. Thanks. And I'll turn it over with that to Dr. Saag. Mike?
Well, thank you so much. Yeah, this is going to be, I think, a fun evening. I'm going to, whoops, I need, while I make the introduction, I need permission to share my screen. But so we have panelists from all across the state, and I'm going to let them introduce themselves. I'll introduce myself first. I'm Mike Saag. I'm a professor of medicine, infectious diseases at the University of Alabama at Birmingham. Sonia, I'll let you go next. Muted.
After a million Zoom calls, I still do it. Sonia Heath, professor of medicine, infectious diseases, also at UAB.
Dan?
My name is Dan Newberger. I'm the assistant medical director of the Huntsville Hospital Emergency Department, and I run our monoclonal antibody infusion clinic.
Darren?
I'm Darren Scruggy. I'm a rheumatologist of all things, a chief medical informatics officer, and I'm associate program director of our internal medicine program. And I also somehow got roped into running a monoclonal infusions.
Wonderful. And Dr. Turner Overton.
Yeah, hey, I'm Turner Overton, also from UAB with Mike and Sonia, and run our monoclonal antibody program. I really worked on HIV and then just pivoted to another RNA virus, so here I am.
Wonderful. All right, I'm starting to share my screen now, and we'll get right into this. This is called COVID Cases from the Clinic. And what I'm going to do is I'm going to present the cases to you. These are my conflicts, basically just research grants from two entities. And what we'll do is we'll have an open discussion among the panelists for about 45 minutes. And we'll talk about therapeutic approaches, especially patients who are older, those basically at high risk for getting real sick, going into the hospital, and potentially dying from COVID. So older, immunocompromised, underlying disease. Also, what do we do with women who are pregnant and develop COVID, the approach to what we might do in that situation. And then we'll have a couple of sidebars into what does vaccination do, especially in those first 12 to 14 days after the first dose. So the way I've organized this is I'm going to start with a question and then go right into a case. The reason I do that is that it enables you to understand where the case is headed. Otherwise, if you just started with the case, you're kind of going, well, what sport am I playing here? Baseball, football, soccer, whatever. So here we go. What's the preferred treatment for a newly diagnosed patient who has COVID? So this is a story of a 65-year-old guy who presents newly diagnosed. Symptoms of fatigue, sore throat, and headache started 2 days ago. Yesterday, the COVID test returned positive, and they had a simultaneous flu test that was negative. No underlying health conditions other than hypertension that's well controlled. His BMI is 26. He's a prior smoker, but hasn't smoked in over 40 years. And his O2 saturation right now is 96% on room air. So at this point, you would recommend, and here's a bevy of choices, you pick the one that you feel the best about right now. And Megan, if we could bring up the poll, we'll see what the audience, how they want to vote. And I think when this comes up, yeah, you see it there for you. And you just tick the answer that you like the best. We'll give you about, 10 to 15 seconds. It's a kind of a long list. You may be looking at some of these answers and going, I don't know what that is. Well, that's part of what we're going to be talking about. So let's give it about another 5 seconds and we'll see what the poll shows. All right, let's look at our responses. All right, a lot of folks, 45%, the most common answer is just support them. 7% of folks would use steroids of some sort. A few would use hydroxychloroquine or ivermectin. And combined, about 50% would use one of the other monoclonal antibodies, and some would use remdesivir. So let me open it up. And again, Dr. Heath, I think I'll start with you. Are you on mute?
So the kind of things that stand out about this case are this gentleman is 65 years old, so he automatically meets criteria for monoclonal antibody therapy. In addition to that, he's within the first 5 days of his illness, and we think it's best if you treat within the first 5 days, but of course have to treat within the first 10 days. So I would recommend either the bamlanivimab or the CASI, as we call it, the combination antibody, and would really try to educate the patient on the fact that we can't predict who is going to have poor outcomes, but the second week is usually worse than the first week. So even though he may have mild symptoms now, the earlier we treat, the better, and try to get him in for treatment within the next day or so.
Okay. Anybody want to talk about any of these other choices? Just chime in.
I think so. I'm a rheumatologist, so I'm in love with most of them. So of course I love steroids, but again, it's probably not the right time for it, and he's doing well enough. He doesn't need them. Hydroxychloroquine, when we first got those reports out of France, I was cheering because I'm like, it's such an underappreciated drug that does so much. And wow, it can be an antiviral as well. And I think we've pretty conclusively proven that that is not the case. Colchicine as well is one of our drugs we use for gout. It seems to make a lot of sense. But again, I don't think that it is actually borne out as well in the data. And then ivermectin and oseltamivir, Tamiflu, don't really work very well, and they're not really specifically targeted to SARS-CoV-2 anyway. So yeah, we tend to offer these patients, they get screened and we offer them the monoclonals.
Yeah. Anybody want to speak to ivermectin?
Yeah, I mean, I can speak to that just a little bit. I think that ivermectin is another drug that has some interest in people. In vitro studies, it showed that it had some activity against the virus, and so that was intriguing. One of the challenges is that the doses that you have to give to be therapeutic will be toxic to a patient's liver. The dosing that we use for parasites are inadequate to achieve levels that would suppress the virus. Furthermore, there has been an evaluation done by Merck, the company who makes ivermectin, and in their review of the data they've seen no effect of the agent against in clinical patients for COVID. So, I would not use ivermectin in this setting. I don't think we have data to support it.
Okay. David or Dan? Thoughts?
I guess I would just add that kind of the most popular choice was symptomatic treatment only. And from an emergency medicine standpoint, we see these people on day 8, 9, and 10, when that's the initial treatment at day 2 and 3, quite frequently. And at that point, it can actually be difficult to arrange appropriate therapy. And as Dr. Heath was saying, if we can get antibody therapy into them within the first 5 days, we think it's better.
Yeah. David, let me ask you to kind of imagine for a second that this is a 36-year-old patient as an O2 SAT of 96 and otherwise as a healthy individual. What would you do for them? They show up in your practice.
Okay, if he does not qualify for the monoclonals, which this patient does not, 36-year-old and healthy, I would start him on symptomatic treatment. Now, I'm using vitamin D, vitamin C, zinc, Pepsid, Zyrtec for symptomatic relief. I also start these people on budesonide. Usually I start them on budesonide fairly early in the course, and nebulization twice daily. Tell them to use it outside so they don't infect the household. And I get a lot of positive feedback on that, particularly some of these people when their SATs start getting down in the 92 level, and that helps.
Yeah. And would you see that 92 level that early, you think, or would that be a little later?
I saw a nurse anesthetist this last week on day 4, one day after infusion. I actually got down into the 70s. Put her on home O2. Actually gave her some fluids. So yes, I've got about 24 people on oxygen at home, keeping them out of the hospital. So we do. It's not common, but we do.
Yeah. Well, these are all great comments. Let me just kind of run through them, and then I'll show a couple of data slides here for us. But symptomatic treatment, of course, what's wrong with that? And David Thrasher just listed a number of things that he does. I think everyone finds their approach, and I think there's pretty good rationale for the things that David said. The steroids I'm going to talk about in a second. Hydroxychloroquine, I had COVID back in March, right when the French study came out, and I took it. My cousin's a rheumatologist here, and I can't say it hurt me. I can't say it helped me. It made my stomach upset a little bit, but maybe that was a disease. I don't know. But later the data came out, and I'll show you some of that in a second. The ivermectin we talked about. Colchicine is brand new. There's a new study that came out, but the effect size, despite having over 4,000 patients, was pretty small. And it's really not, it's something I think we still need to look at, but there's not much in the way of antiviral activity. We're going to talk a lot more about those items 6 and 7. Remdesivir would be a great choice if it was oral, right? The concept of using an antiviral early on makes all kinds of sense. That's what the monoclonals do, and that's what remdesivir would do. The problem is it has to be given IV over 5 days, and that's a problem. People in the hospital, yes, but because they're there, but outpatient, that's a challenge. Oseltamivir I just threw in there because that's Tamiflu, and it has no activity at all. So I made the point saying the guy was flu negative. So let's look. This is today, I pulled this off the web, the NIH treatment guidelines, but you could look at IDSA, you can look at the European group, that basically they recommend not just neutral, they're against the use of hydroxychloroquine with or without azithromycin for hospitalized patients, and non-hospitalizations they recommend against, except if there's a clinical trial that it's worth checking that out, and against high-dose chloroquine because that becomes toxic. This is a statement that Merck made a few days ago, maybe almost a week ago, that says unequivocally, this is their drug. They use it for, it was originally approved for onchocerciasis or river blindness, especially in sub-Saharan Africa, works really well for scabies. So it's an antiparasitic drug. But they say unequivocally, no scientific basis for potential therapeutic use from preclinical studies, no meaningful evidence from clinical activity or clinical efficacy, and a concerning lack of safety data. And I think, as Dr. Overton pointed out, the dose isn't really worked out for this. So a lot of confusion. All of us, I think, who have been out in the public on this have taken a lot of heat, as if to say, well, you've got something against this. You don't like the idea that that this is coming up in ways that maybe are a little bit non-traditional, I think I could speak for every panelist and say, no, well, I'd love for this to work. I'd go crazy over that. Or colchicine, even better, although it's now costing $140 for 30 pills. Used to be $14 or maybe for 90 pills, but I'd love for that to work. It's just that the data just aren't there. And I think that's what we're struggling with. Let me go through the issue of steroids just a little bit. And this, I think, might be helpful just to understand or go over the biology. So what we see is that after initial infection, people start to get sick, and it stimulates an innate immune response. Think interferon. And that's an antiviral, but also an immune modulator. And then that triggers or interacts with the so-called adaptive immune response that starts to peak at day 10 to 15. That's antibody. That's cellular immune responses that are targeted against a specific antigen, read the virus. And that's how this works. The interferon response, in my view, is essential. And to me, if you take no other slot away from this entire endeavor, this is the important one. Why? Because in the people who do well, the virus comes up, the interferon spikes, that's good, early. And then it comes down and it drives the virus down with it, usually by day 7 or 8. In the people who do poorly, the viral load goes up and it keeps going up, partly because the interferon response is blunted. It sometimes happens in older people. It sometimes happens in people who are immunocompromised. And it happens in people who on day 2 or 3 get a slug of steroids, dexamethasone IM. As they go to a treatment center, they get an acute rapid test. It tests positive, and on the way out the door, oftentimes they'll get a shot of dexamethasone, a shot of Rocephin, ceftriaxone, and off they go. That's perhaps one of the worst things you can do, because it takes someone who otherwise might have controlled their infection well, and it messes with Mother Nature and the interferon immune response. That is a problem for the patient, and ultimately down the road, when they come into the ER on day 10, 11, or 12, worse. The other thing to keep in mind as we're treating this, and this is also underscoring the value of antivirals early, in the first 5 days, especially, out to 10, but earlier better. If somebody has a low inoculum, low dose, low exposure, they end up getting rapid clearance. People like myself, when I got COVID, I was in a car for 20 hours with my son, who unbeknownst to either of us had the virus, just in early March, driving from New York to Birmingham. In a car, breathing, windows up for 20 hours. I got a hefty dose. I got pretty sick. And that can lead to these cytokine storms and that type of thing. The low viral burden can be controlled by the interferon. Higher viral burden escapes, and that's when you get into host damage all over the body, and is associated with a lot of these cytokines that rheumatologists know well, and that we know also creates what's called the cytokine storm that can be very at play, especially through days 7 through 14 and longer. This is the way I like to think about it. In those same stages, you have antiviral stage and an inflammatory stage. Here is when remdesivir would work best. We oftentimes aren't using it until day 10 to 14 because of the circumstances. So if we had an oral remdesivir, wonderful, right? But the monoclonal antibody is our next best choice. It does require coming in to an infusion center for 1 dose. So now that we've covered the basics, let's get into some details on how we might be treating people mid-range. So this is a person, what do we do for people? Onset of symptoms about 6 days ago. What I'm finding, and I'm sure you are too, is the notion that people get sort of sick and they aren't sure, they don't think about COVID until they lose their sense of smell, and that could be day 4 or 5, and oh my goodness, I might have COVID. They get tested. So here's a 36-year-old patient who comes in newly diagnosed. The fever, fatigue, dyspnea started 6 days ago and progressed. She got a COVID test yesterday. The flu test was negative, has some hypertension and diabetes. Her BMI is 47. Oxygen sat is 95. Now, these are our choices. Let's see how we vote this go round. Let's bring up the poll. So you have a choice here of either one of the monoclonals, dexamethasone, we are now at day 6 or 7, hydroxychloroquine with zinc perhaps, ceftriaxone, levofloxacin, remdesivir, ivermectin, or just the inhalers that Dr. Thrasher told us about. Okay, let's see what we have. All right. Over 3/4 want to use a monoclonal, even though she's 36 years old. Some would lean towards dexamethasone now that we're at day 6 or 7. Let's reverse the order a little bit. David Thrasher, I'll let you go first.
Well, I would definitely give the monoclonal, and I would start on the, maybe not albuterol, but I definitely give her a budesonide. Every patient I do, I make them get a pulse oximeter day 1 and check back with me each day, see what the stats are. And I would try to, I like to get 8 days in my pocket before I give them steroids. Now, if this patient was really sick, I don't have any problem giving steroid here, but I like to get 8 days without steroids before I give them the prednisone or dexedrone.
Yeah, it's kind of in the gray zone, isn't it?
Right.
Let's see. How about Darren? What would you think here? You might be muted.
You may want to call.
We should never do that. Yeah,
Oh,
so
sorry.
I would of course be leaning towards the monoclonals here. She's not sick enough to be in the hospital and to need a lot of the other things. You know, I tend to get on my residents because they all believe that they must have concurrent bacterial pneumonia and they need Rocephin and azithromycin anyway. And I'm like, you know, they really need the supportive care as well. And I think the inhalers, the cough suppressants and things like that. But yeah, I would stay away from just throwing the antibiotics at them as well.
Okay. Dan?
Yeah, I would agree with that. Monoclonal antibody. This is a patient population who we're probably having the hardest time convincing outpatient providers to refer to us, because it pops into everybody's mind that everybody over 65 should be referred. But the 36-year-old who walks into your clinic, because every other 36-year-old who's healthy, you're just sending home with supportive care. You've got to not do this for this person.
Yeah.
So yeah, Mike, I want to follow up on Dan's comment, if it's okay. We underappreciate the role of obesity, and particularly morbid obesity, in this illness. In the hospital, the sickest patients that I see are not the 70-year-olds. They're the 35-year-olds with morbid obesity. And part of that may be because they have such a robust immune response, and the fat is really driving this inflammation. They're the ones who get this cytokine storm and get in such terrible ARDS problems. So we need to be really aggressive at treating these young people with morbid obesity. Furthermore, the consequences of serious disease in these people can be really overwhelming. And while they may survive a complicated long ICU stay, they're looking at a really difficult rehabilitation process. So if we can prevent, you know, one illness in a 35-year-old, that is just tremendous.
So it sounds like we're having consensus, and Sonia, I'm going to turn to you in a second. But Turner, before you go, what would you do about steroids here? We're probably about day 7. You're going to try to give monoclonal antibody. You just expressed concern about the BMI of 47, 48. Is this the time to pull the trigger on that, or would we wait a little bit?
I think I would wait in this case, but you know, I would agree with David. I think once you're into the second week, if someone is having, you know, prominent inflammatory symptoms, then I would consider. I generally do agree. I like to wait a little bit longer before giving steroids, because I really don't want to blunt any of their innate immune response, as you pointed out earlier.
Yeah. So this is why it's so subtle and so hard to create a mindset around steroids, because everyone saw the data from the resolve, this relief, what was it called? The study that showed that showed
Discovery trial.
that showed the dexamethasone worked, but that was in hospitalized patients after day 8, 9, or 10. But early on, it's actually almost contraindicated. So we're in that transition period. Sonia, I'm going to turn to you for the last comment on this, unless others have some things to add. But let's go back to the antibiotic use. I think it's clear that for your average run-of-the-mill COVID case, even if her chest X-ray showed some patchy infiltrates, you're not seeing our bronchograms. There's no sputum production to speak of. What would be the things that say, we probably need some antimicrobial therapy here?
I do not give antibacterials to people with a viral infection in the outpatient setting, very rarely. And I think the key is, first do no harm. And I think Dr. Thrasher, made the comment of contacting patients and checking on their oxygen saturations. I spend a lot of time talking to patients about controlling their fever, maintaining their oxygen saturations, and maintaining their fluid status. After they get monoclonal antibodies, it's going to take a couple of days before that viral load comes down and the inflammatory response comes down. So for that 2 to 3 day period, the best thing that we can do for them to keep them out of the hospital is to keep them well hydrated, well oxygenated, and keep their fever down. So oftentimes we'll get a referral of somebody and they've already been put on azithromycin, colchicine, ivermectin. They're having a lot of diarrhea. They're very nauseated. They're trying to push fluids, but they can't hold them down. And so we give people a lot of fluids because they're so dehydrated.
Yeah.
So, I try not to stop things that physicians have started if they're not harming them. But I do think we do have some patients that the nausea, vomiting, and diarrhea is definitely, it's tilting them towards hospitalization if we can't maintain that. So I really try to avoid that unless they are, the majority of these people have a chest X-ray with bilateral infiltrates, which is consistent with a viral pneumonia. Right.
So these are some data here. Looking at age and BMI. So as Turner said, BMI is a problem, and it gets above 40 to 45. There's a lot of problems, especially with mortality, and then age, as we've talked about. But even among young people with high BMIs, there can be issues. Just real quickly, some background on these. This is a Regeneron combination antibody. What you're looking at here is placebo versus 2 different doses, and this is solely looking at viral load. So you get the sense, okay, it's working as an antiviral. Same thing true for bamlanivimab, and those of you playing the home game on Jeopardy, the BAM comes from Alabama because the person at Lilly who helped drive this through in development was originally from Alabama and went to Auburn. But you can see almost a 1 log difference in viral load there. BAM is now, they're looking at a combo of bamlanivimab with eltesevimab, and that the combination is looking pretty good. And these are the clinical data. People say, yeah, but what are so this is a study that really wasn't designed solely for high-risk patients. It was kind of all comers, randomized trial. There was a 70% reduction in hospitalization, but there was no deaths in that group. Now, when you break out the high-risk people, there was even better outcomes. So this is and I think anecdotally, let me just pause for a second and get you guys just to chime in on what your numbers have looked like. David Thrasher at Montgomery, how many have you treated? What's the numbers look like?
We've probably treated over 400 now. I think we've had 2 patients. I had one, somebody else had one that had to be in the hospital. One I just told you about, who actually we infused, but the BMI was 45, 34 years old. And we've had no deaths.
How about in Mobile?
We've done, I was just looking at the number, somewhere north of 1,200 infusions, and we've done really, really well in terms of not having very many come in to the hospital afterwards. We've had a couple that have come in right there, as I think Dr. Keith was mentioning, they're on the edge. They've had diarrhea, they're dehydrated, their oxygen sats are a little bit low, and you're like, you know, if I'd only gotten this in you yesterday, you know, I would really feel much better. And now I feel like I'm right on the line there between whether you need to come in the hospital or whether we can get the magic in you fast enough.
Yeah.
But yeah, we've done a lot and really been pleased with the results.
How about up north?
We're just shy of 600 infusions. We're running about 2 to 3% hospital admissions. And over half of those, I would say, are probably unrelated. We've had admissions for everything ranging from suicidal ideations to DKA in patients post-infusion.
Yeah.
And I would agree, the ones who ended up being admitted for COVID-related symptoms were almost uniformly same day or next morning admissions to the hospital.
Yeah.
So probably just a little bit late on getting the infusion in them.
Right. And UAB?
We've had about 630 people infused and about 15 hospitalizations. Several of those are directly admitted from the infusion unit. We've had people say they were so sick they needed to go to the ER first, and we begged them to come to the infusion unit first, get the antibody, then get admitted. I will say that of the people who have been admitted, we've had nobody admitted to the ICU, and all of them have been shorter stays. Within that 48 to 72 hour, they turn the corner, get well hydrated, and they're able to come out. Dr. Thrasher also mentioned, you know, giving people oxygen and setting up home O2, which I think somebody mentioned in the chat. You know, we do try to identify that in the unit so that we can keep some people home, because often it's just a week or so of oxygen.
Yep. So, I mean, I don't know what our rates would have been because we're not randomizing, and good. Fortunately, I think as Dr. Williams had said at the outset, I think in January, at least at our hospital, and it sounds like others, this went a long way to decompressing both the ER and the hospital. It was a big deal. The variants we mentioned, I'll just show quickly that so far, there seems to be little impact, even with the South African variant, on these monoclonal cocktails. So far, those look like they will still work, but variants are variants, and a new one's likely to emerge in April and May and could be totally different. So just to review the conditions for monoclonal antibody, and we're going to have a couple of handouts for you that you can access, I believe, through the Medical Association website. But the morbid obesity is at the top of the list for good reason. Type 2, this is anyone. Type 2 diabetes, chronic renal disease, any kind of immunosuppression, age over 65, and those who are over 55 if they have cardiovascular disease, hypertension, or some sort of chronic lung disease. So let's go. We have a couple cases left here. What's the preferred treatment for a newly diagnosed patient with onset of symptoms greater than 11 days ago? So this is an older, well, old is now relative for me, 72-year-old lady, diagnosed, had fever, fatigue, dyspnea on exertion, started 11 days ago, 3 days after her first COVID shot. So initially she got her shot. 3 days later, she starts to feel ill. She thinks it's the vaccine, but she went and got tested and she's positive. She's got osteoporosis. Interestingly, she had lupus and was on hydroxychloroquine. So for rheumatologists, there you go. BMI is small, slight lady. O2 sat 96, but drops to 94 with walking, and has these, as Dr. Heath pointed out, these scattered ground glass infiltrates that don't look like bacterial pneumonia. So now you're going to give Dr. Thrasher's inhaler. What else are you going to do? Go ahead and vote. Normally I play some sort of music here, but I wasn't quite adept at doing that. So, and I'll spare you from my singing, which I'm sure you're grateful for, even though you don't know to be grateful for. All right, let's see what we would do here. Ah, fantastic. Yeah, I should have probably taken the albuterol and the beclomethasone off because I said in addition to inhalers, so that was a little bit unfair. But looks like a very sharp audience here. Uh, Dr. Overton, do you want to comment?
Sure, I'd love to. So I think this is a challenging situation and somewhat frustrating. So we've got to follow the guidance of the FDA, and for the EUA, we've got to give the monoclonal antibody therapy within 10 days of onset of symptoms. And it is really data driven because it's an antiviral. It binds the virus and helps clear it from the body. And so by day 11, theoretically, most people are no longer having infectious virus, but it's more of an inflammatory disease. Now, so that's the rule, and that's what we have to follow. One of the challenges in an area, a gray zone that I think we still don't know about, are people who are immunosuppressed, and they shed virus longer. Should we give them a longer window before when we can give them the monoclonal antibody therapy? Right now, the answer is no. We have the hard and fast rules based on the EUA, but I think that's a population who shed live virus longer and would probably still have a benefit. Now, she's not the most immunosuppressed, but she does have an immunosuppressive condition. Her medications are not terribly immunosuppressive. But I think that with her having these infiltrates, that's probably more inflammatory than infectious. And I would lean to giving her oral steroids, or at least watching her very closely and pulling that trigger if she starts to decline at all.
Any dissenting view from the panel? No, I think we all agree with you there, Turner. And it looks like we chased everyone away from antibacterial therapy. Good. Remdesivir, sure, if we were going to admit her, that maybe, but it gets back to the only question to me is how immunosuppressed is she? And I doubt much on hydroxychloroquine. I would have loved to have used that on day 2, but she had that situation. So let's clear the poll.
Can I make a comment there?
Yeah, please, Dave.
I think it's very important. The 100 people on this conference know this, but it's very important not to spend too much time when they test positive. You have to put that on the sheet to get the monoclonals. But I spend a lot of time, and I tell the people, this is very, very important. When was your first symptom? Try to nail that down from day 1. Because, day 11 or day 9, we don't really know unless you really spend some time up front on when that first day of symptoms. I've given day 11 when they were so sick, this and that. But if you spend a little time and get that first symptom, it's going to help you a lot.
I'm so glad you mentioned that. I don't think we could be any stronger in our imploring everyone to think about this disease from onset of symptoms. That's our anchor. That's what drives everything we do past that point. On this slide, I was just trying to make the point that if you look at this inset here, this is looking at this is the Pfizer drug, and notice how there's no difference in the onset of symptomatic cases in the study of tens of thousands of patients. You don't see separation really to day 12 to 14. So here's a woman who got a vaccine. She happened to get sick around day 3. That happens. I'd also maybe think about it, whereas by the time she's here at day 11, which is roughly here, she's probably making some of her own adaptive immunity here in her own antibody, but we can't count on that necessarily. But the thing I want to make the point of is that a lot of patients we're seeing a fair number actually, who come in on day 3, 7, 8 to get monoclonal antibody infusion after they'd gotten their vaccine. All right, let's talk about pregnancy. So this is a 26-year-old pregnant lady who had symptoms of fatigue, sore throat, headache 2 days ago. She's in her 3rd trimester. I didn't put that here. COVID test is positive, flu test negative. She's 7 months pregnant. I did put it there. So would you use monoclonal antibody here? Yes, no, not sure. She's not obese, doesn't have any underlying diseases, and the only thing is she's pregnant. Give about 5 seconds more, and let's see the results. Okay, we're kind of split. Anybody want to take this one?
I will start out, Mike. I would not treat. If you told me she was type 2 diabetic or a BMI over 35, I would treat.
Okay. Anybody else? Anybody feel a little bit more
I think we're in a data. So there are no data available to us in pregnant women. That being said, monoclonal antibodies are used, and frankly, passive immunizations, which this is a passive immunization strategy, are used in other infectious diseases for pregnant women. We have treated pregnant women who had immunosuppressive conditions or had a high BMI. And other institutions are doing that as well. I think the key thing is to talk to the person's OB and make sure that they're on board, and also the patient, and say, we're in a data-free zone. We don't have any data in pregnancy, but this class of medicines is very safe in pregnancy. Monoclonal antibodies for other diseases are used in pregnant women. And then furthermore, we do passive immunization strategies with IVIG or other things for pregnant women.
Yeah, and as I look through the early use authorization, they do have a little wiggle room on pregnant women. I think for all the reasons you said, I'd have to triple check before I wrote the prescription, but I think this is something where we could justify for all the reasons you said. So it's just something to think about as we move forward. Moving forward, here's
I would just reiterate that this is a good time just to educate the physician, as Turner just mentioned. Oftentimes our OBs maybe don't know as much about these treatments. And like David said, they do have at-risk patients. They have patients with obesity. They have patients with diabetes. And so even if that patient doesn't need the treatment, the opportunity to educate their OB about this treatment and for future referrals, I think is key, because there are some, bad outcomes in pregnant women with COVID. So Great time for education.
Okay, this is our last case. Complicated, and it's real life. Unfortunately, those are always more complicated. 52-year-old lady, 5 weeks ago, improved over 18 days, had a course of steroids. She had fatigue and fever, dyspnea, returned 2 weeks ago as the steroids were tapered. Her COVID test has been persistently positive. That's not a surprise, but the COVID antibody is negative, and now we're many weeks out. This is 5 or 6 weeks ago. She had an underlying lymphoma diagnosed within the last year and has been on rituximab. So her O2 sat now is 92. She desaturates to 89 with walking, and she's got ground glass infiltrates. And I'll add that the 2 different CT scans have shown infiltrates, but they're in different locations, right? So it starts off in one area, that kind of clears up, and then it appears in a new area. So I'm going to take this out because take it out of the EUA and just say to us, if this were an approved drug and there's no EUA restriction, would you pull the trigger on a monoclonal antibody in this lady on Rituxan? And I realize we're off label. Sorry about that. It's not meant to be used in today's world, but maybe in the world 2 months from now when it maybe gets approval. Let's go ahead and vote under that circumstance. Complex. Okay, let's see what we got. All right, let's hear from our rheumatologist. What do you think?
I love Rituxan. I was just giving some today. So of course it's a tremendously good B-cell depleting therapy, and I think specifically, what it does is it takes out those guys that are in the middle, sort of in the trenches, waiting to become effective immunoglobulin producing cells. It doesn't get your memory cells. It doesn't get your precursor cells. So it's great therapy for lupus. It's probably one of the worst things you could have, with something like COVID, because as those are the cells you need, as she demonstrated, to make your antibodies. And so we know that specifically that therapy is really putting her at high risk for her immunosuppression, being unable to effectively clear the virus. So it would not be surprising. Those are the patients that have, recoverable virus out 20 or more days, as opposed to the 10 that we would normally think of. And that's also where we can have a lot of the viral replication ongoing and mutations occurring. So yeah, I think this would be a good use case for a monoclonal, because she can't make those antibodies herself, and she's kind of demonstrating that the virus is kind of still there doing its thing.
Perfect. That's why I brought it up. I don't know what to do exactly in this. I'm very worried about people who are on Rituxan for all the reasons you said. And we'll find out over time what might happen. We don't have time to go in this today on because of we're focused on the acute therapy, but maybe we'll have another one of these webinars in the future on long COVID, which is a long-term complication of COVID, which has multiple myriad of presentations, and no one knows quite what to do. But I think this is one specific example of where long COVID is going to be an issue for this lady and a lot of others. So what we didn't cover today, how to treat someone who got steroids on day 2, now day 8. I think, as you've heard, we kind of do the best we can. Just briefly, we're actually out of time, but anticoagulation, we know that clots form during these cytokine storms, but whether you just use a little bit of aspirin periodically or whether you would use a specific direct anticoagulant, don't know. But we didn't have time for that. I wanted to finish with some hopeful notes here. This is a drug that Merck is developing. It's a nucleoside agent that was, it's a cytidine analog, which usually means it has toxicity. We saw a lot of that with DDC in the AIDS era and caused a lot of neuropathy and some pancreatitis and fatty liver, but we're only talking about 5 days worth of use. It's actually pretty active. This is I think that's a ferret model of COVID. And you can see that you got clearance of virus in 1.5 days with the 2 lowest doses. And then you say, wait a minute, the higher dose took longer. Well, that's because they gave them 3 times the inoculum. We talked about viral load, but it still cleared it on out. So that's pretty promising. That's moving into clinical trials. So this is the drug or type of drug that we would love to have, right? It's kind of a similar to remdesivir, orally bioavailable, and maybe we'll have something like that. So how do I access? We're going to distribute locations that hopefully will be near you. If it's not in your hospital, the sites will have a primary contact individual and information. The general rules of eligibility that I showed earlier will be clearly put there, and where to call for questions. The key thing, got to make these diagnoses early, and as soon as you get the diagnosis on someone who's eligible, get them into the center as fast as you can. Time really matters for all the reasons we've talked about. Viral load, highest early, best time to use it is then. That's the best shot that we got. So I think I'll close there. I think we have, we left enough time. I'm going to stop sharing, and we're back.
Dr. Saag, this is Mark. Let me,
Hey, Mark.
let me chime in right there. So we do have a list of the sites that the Hospital Association has been kind enough to share with us that are hospital-based sites. There may be some additional physician-based sites out there that we don't have, but we've got that, and Megan can share that, and then we will also post that on our website, and I'm assuming Alaha will post that on their website as well, so anybody can go back and see what sites are in your particular area where you can refer patients.
Perfect.
I just put that Google sheet into the chat, so you can copy and paste that link, and that will be to the sites where the infusions are available.
Yeah,
Okay.
and this is Dane Howard, Dr. Saag. I'll make one more comment that there is another resource to see where clinics are throughout the entire country, but in Alabama, it's HHS Protect turned it live. And so every place in the state of Alabama who has received a supply of any of the therapeutics now are listed. Now, there are no phone numbers on there because it is a public-facing site and for people to use. But the sites at least are obvious on there now. So I sent the link late this afternoon to Mark. So we'll make sure that gets out to everyone as well.
And then we'll include your cell phone so people can call you for the, I'm just kidding.
Or
Just
yours.
kidding. So we have a number of questions. We're going to do this rapid fire to get through them all. So I'm just going to pose the question and just somebody jump in and answer, and we're going to have kind of a free for all here. So Do you think the Regeneron dual antibody has more benefit than the monoclonal antibody, single?
No, not yet.
No.
But I will say one thing that is concerning. I mean, the nice thing about these mixture antibodies is that theoretically, if you have a resistant virus, you're targeting two different epitopes. So if we start to see, you know, some resistance, then it may be beneficial. There doesn't seem to be a downside to using one of the combination antibodies, at least with the two we have. There doesn't seem to be an increase in side effects.
Okay. Dr. Thrasher, you mentioned the use of vitamin D, C, zinc, Pepcid, Zyrtec. Can you speak to the notion of that as a preventative? Should people just be loading up on that as they get their vaccination to get protection?
You know, I've never been a vitamin fan in my life, but I've been reading a lot on vitamin D since this thing started, and it does have a lot of positive effects. We've been routinely checking vitamin D levels when they come just from my own application to the hospital, and a lot of these people have very low levels.
All of them.
Hurt.
Yeah.
It doesn't hurt. So I tell them, I give them 5,000 vitamin D and 1,000 vitamin C and hope.
Yeah, well, Paul Sachs, literally today from Harvard, has a blog that's fabulous. He's got a great sense of humor on vitamin D. He actually went there. And the thing he points out is that universally, almost, people who are sick and in the hospital have a low vitamin D level. The problem is that replacement doesn't work for a lot of people. So it's a very controversial area. But at the end of the day, he said, yeah, maybe we'll still use it. Dr. Heath, is there still a use for remdesivir?
Is there still use for
No,
remdesivir?
is there indication that since it's being used late, is it just kind of a...
Oh, yeah, that's a good question. I mean, I think once you've had monoclonal antibody, it probably has less use, but we haven't studied it. So a data-free zone, but if you've cleared the virus with a monoclonal antibody, it is unlikely that you get a lot more bang for your buck by giving remdesivir after the fact.
Right. Dan, side effects of the monoclonal antibody, and do you pre-medicate with anything?
We have not been pre-medicating. Side effects, it's difficult to tell if they're from the drug or from the disease. But most commonly, you might have a patient have nausea, diarrhea. The concern is anaphylaxis, of course. We have not experienced that in our infusions, but there was one case in the trial that led to the EUA. So.
Yep. And I don't know about you guys, but anecdotally, as I've covered there, I have noticed a few people at the end of the infusion or as they're leaving get nauseated. And even when they get in their car, they sit down and they need a bag. So there may be something to that. It's hard to say.
We have Zofran on hand.
Yeah, exactly. We use a lot of Zofran. But then by the next, several hours later, it's gone. Can we discuss the differences? Sonia, I hate to come back to you, but about convalescent plasma, you've run a study on that. So quickly, if you had to choose between convalescent plasma, monoclonal antibody, they're both available.
So I think in that last case that you presented of a person who, was late and probably still viremic, we've actually used high titer convalescent plasma in cases like that and had patients who are febrile and melt their fever right away and get better. So I think in the absence of, an available monoclonal antibody in the hospital, if you can titer your antibody in the hospital, because a lot of convalescent plasma does not have high titer antibody, it is very useful to use in those situations. I think the final studies and what we've seen so far looks like it's beneficial early on and with high titer.
Okay.
Monoclonal antibody in a bag is going to be the best thing for most people and widely available.
Right. Darren, can individuals who have been fully vaccinated and then let's say a couple months later develop COVID still receive the monoclonal antibody if they meet criteria?
Well, that is a good question. I don't think it's in the data-free zone. But of course, we've tried our best to get them high quality antibodies to specific portions of spike protein. And so what we may see is that, with escape variants and different antigens and epitopes, that you may still get some benefit. But I think that's a very good question, but we're definitely in a data-free zone there.
Seems like first off, I think it's going to be uncommon. Second thing, I'd check that variant right? To see if it's an escape, that would be good to know. But I agree with you. I would treat if they met criteria otherwise. Dr. Heath, one of the audience members wants to know, why do you try to control the fever? Isn't that a part of the innate immune response? Should let them, get overheated a little bit and kill those rascal varmints that are causing the trouble?
They've already generated an immune response, which is causing them to have the fever. And at this point, I think the fever contributes to a rise in their heart rate, which can result in a decrease in their oxygen saturation, which is not good, or contributes to dehydration, and that's also not good. So I try to tell people to keep their fever controlled, to try to keep all their vital signs stable until this monoclonal antibody can help them turn the corner in a better direction.
Dan, let me throw this question to you about, basically, since monoclonal antibodies are mostly in the hospital setting, it seems like it could be valuable to have it attached in some way with a universal testing center. So let's say there's a drive-through testing center, somebody tests positive, you screen them. Hey, you're eligible. Could you just shuttle them off and do that there? Would your ER be willing to staff that and make it happen?
Yeah, so that's actually why it's not being done in the ER. But our hospital-based testing site is actually our infusion center as well in Huntsville. And so we've kind of have this dual purpose. But I agree, that's the trick, is getting people referred early on in disease. I actually had one of our nurse practitioners go around to local urgent cares this past week with a laminated sheet because they're doing high volume testing. To try to recruit more people, essentially.
Right. Dr. Thrasher, how do you get home oxygen? Seems like there's a lot of hoops to go through. What's your trick?
Well, there used to be a lot of hoops to go through. We do, I'm pulmonary critical care in Montgomery, so we do most oxygen probably in the town. I went to a couple of the oxygen people. I said, look, I'm going to call you at 7 o'clock at night, midnight, whatever, and say, this patient needs oxygen. Trust me, go ahead and deliver the oxygen then. I'll do the paperwork later. Usually they have to have a report from your office to get it. I said, nope, I want to do it right then. And so go to your oxygen company up front, make the deal. And the patient's already called me, told me he got a O2 sat of 87. So I'll fill that out later, and they get the oxygen that night.
Right. Dr. Overton, let me turn this to you. Data for steroids in a patient without hypoxemia.
Yeah, from the trial, when they looked at the data, the people who benefited from the dexamethasone were people who were hypoxic and ideally needed supplementary oxygen. So, if someone they really need to be 93% or lower to benefit from steroids, at least based on that study data. And so I think that we should stick with that in terms of using that. Now, there may be patients later in the course of illness who you're giving steroids, for post-COVID type symptoms. We work with our neurologist, and often for these people who have a persistent brain fog and headaches, they'll try a course of steroids. And sometimes for other reasons, if people are having ongoing fevers into the second and third week, we'll try a course of steroids. But that's a different issue, I think, than in that when they're still in that first couple of weeks with active, what we consider infectious COVID.
Okay. David, I think this question comes back to you because it's about oxygen and whatnot, but as a pulmonologist here, you got a COPD patient, 68 years old, infusion on day 8. OSATs were 88 to 93 on room air prior to the infusion, home oxygen. How long do you expect that home oxygen will be needed? How long does it take, in your experience, for this person to recover?
Well, 2 questions. One, if patient is on oxygen, you can still give the antibody, monoclonal antibody. If the oxygen level is going up and they're not on it, you're not supposed to give it. But COPD patients that we have, we put on the oxygen. I watch them a lot closer than most people, but sometimes 2 and 3 weeks.
Yeah. It's all about the response. But I think I think all of our experience, Darren, maybe you can comment on this, is it seems like, in the couple of days, especially they come in day 4 or 5, you give them the monoclonal antibody, even if they're at high risk, usually by day 8 or 9 after onset of symptoms, they're kind of turning the corner. Is that what you're seeing?
Yeah, we see that it's that you know, you're holding on and saying, please, you know, give it time. It's got to get in there. It's got to work. And, you know, if we can get through this 48 or 72 hours after we've gotten the medicine in there and before it fully works, that, you know, it's that time window when you know you've done the right thing, but it hasn't yet manifested, that you see that a little bit of worry. But usually then, you know, by day 8 or 9 or, you know, 10, they turn around and everything is good, or
Right.
at least better. Yeah, and that's what we have seen.
Dr. Overton, want to make a comment about home oxygen.
Yeah, I just want to point out to people that home oxygen it's based on an O2 sat, and so they have to have a documented O2 sat of 88 or below. But, you know, sometimes people are sitting there at 91, 92. If you get them to stand up and march in place for 1 minute, they're going to go there. And then you just need to document it, and you put in an order that says home oxygen administration if you have an oxygen company like David said, and they will provide the oxygen at the level that you state. You need to state a specific level, whether that's 2 liters, 3 liters, 4 liters. Home oxygen is not comfortable going over 4 liters. That's just a practical thing. And they prefer 2 or 3, but they will go up to 4 liters at home. And then, like David said, you need that person monitoring their home O2 sat, and then you need to correspond with them and, you know, titrate it down. And ultimately that can be done by phone. The home health company will be going out to assess the patient as well to get the equipment. So they will also provide an assessment. So it is totally doable, and, you know, that can keep people out of the hospital.
So we are a little bit over time, but I thought this was incredibly dynamic, informative. I learned some things as well. I thought this was just great. As we close, I want to address 2 quick things. Some people are asking about costs and how to pay for this. Well, the government's already done that for us. We have to cover the cost of the infusion centers, but the actual medication is supplied because the federal government paid for this in bulk, and our state has been great about getting it into the state and distributed. And there was a little bit of a hiccup early on, but I think thanks to the work of Dr. Williamson's group and the Medical Association and the State Health Department, that's been worked out. The second thing that came up, I'll just address quickly, was about the people that got vaccinated and get sick on day 4, 5, or 6. And they're hesitant to get any kind of treatment because they think that it's going to interfere with their second shot. And the message there is, sorry, it's the infection that caused you to have to delay your second shot. But look at the bright side. The lines will be shorter in May. So that's a good thing. I cannot thank the panelists enough. It's been just great. Every one of you has been superb. I think I'll turn it back over to our host and let them have the last word. John?
I do want to thank everybody for your participation tonight, and I agree with Dr. Saag, an incredible panel, very useful information. Mark, I think you said you were going to post this somewhere so folks that missed it can look at it later. Hopefully that's the case, but again, on behalf of the Medical Association, we certainly appreciate our panelists and appreciate all of you joining us tonight. Don?
Yeah, I'll echo John. Thank you so much for being on the panel. This was absolutely outstanding. And Mike, it was a wonderful way to learn science and medicine again with the case studies. So thank you guys and ladies, and thank everybody who was